It's me, Jen again, and today we're going to be joined by not one, but two doctors. Stick around. Thanks so much for watching today. If you haven't already, please hit that like button and consider subscribing so you don't miss any of my new videos. Today, we're going to be joined by not one, but two doctors, Dr. Jules Aljammal and Dr. Shahzah Ahmad from the Thyroid Clinic in Salt Lake City, Utah. These doctors were my very first exposure to anything related to RFA, and I'm so excited to be talking with them today.
Hi Jennifer, this is Dr. Ahmad and my partner Dr. Aljammal.
What are each of your medical backgrounds and how did you come into joint practice?
I've been an endocrinologist since 2005, 2006. I finished my fellowship at Harbor UCLA. I have been doing a thyroid-only practice for the better part of almost 10 years. I had a vision of a specialty cutting-edge thyroid-based practice, and I was lucky to get into that situation 2011, 2012, and I wanted somebody who shared my vision. I was lucky enough to meet Dr. Aljammal. We teamed up back in 2014. We've been working together ever since.
I went to University of Pittsburgh Medical Center and I did my residency and training for fellowship in endocrinology there. At the end of my fellowship, I recognized that my main goal is really to practice in a thyroid-only clinic. I was lucky when I was searching for a job to find an opportunity here in Utah. I joined Dr. Ahmad in 2014. I've been practicing as an endocrinologist for the last 5 years and been practicing physician in the United States for the last 10 years. Really, we focus together on thyroid and treatment of thyroid disorder, and we have been working together to get new technology for treatment patients with thyroid disorders. We kind of explored many different options.
How did you get your start in thyroid RFA and pioneering non-surgical procedures for thyroid in the U.S.?
We were aware of non-surgical options for treatment of thyroid disease for a number of years. Me and Dr. Aljammal had been researching and looking into it even back in 2014. We were aware of the pioneering cutting-edge work that Professor Bake and others in Italy were doing. At that time, no device for RFA was available. We tried to work with a company which had a similar device. There was a microwave device, and we were trying to work with the FDA to get that approved for a clinical trial, and that process took a long time, and during which RFA became available in the US. The way we got in touch with Dr. Bake is that we were invited to come to one of his master's courses in Los Angeles.
In March 2018, the first master course for radiofrequency ablation was in California. Me and Dr. Ahmad were looking in different technology. We looked at microwave ablation, we looked in HIFU. We kind of evaluated multiple choices. When we got invited about RFA, in the master class, they shared with us that the FDA is working, and I think was basically a week or two after they got their approval for soft tissue ablation. And at that point of time, we knew that this is the next step. Rightly decided I need to go to South Korea to get everything set up and ready for RFA.
Going to South Korea and working with Professor Bake was a revelation. He is a master clinician and an amazing scientist, very astute, an original thinker. I spent the better part of 7 to 10 days over there. With his support and his advice, we were able to start working on RFA technology here in the US.
When were you first able to offer RFA for thyroid nodules?
The first clinical trial that was done on RFA was published by the Mayo Clinic. But they used a different device with a much thicker antenna, and also they performed the device under general anesthesia. I think we were the first endocrinologists to do an outpatient radiofrequency ablation using a dedicated thyroid antenna. This was back in 2018. I believe our first cases were in November.
The first 3 cases were all successful RFA treatment.
What are the different ways that you've been able to use RFA to help patients?
Can it be used for the parathyroid? That is a difficult question to answer right now, as we don't have enough evidence and data to detail its use in the United States. It's been done for parathyroids in Korea and Italy. We in fact are the first and the only endocrinologists who've done a radiofrequency ablation for a parathyroid. But we've only done one case, and that was special circumstances. It was very successful. Technically, this can be done, but this is still not considered a mainstream first-line treatment modality for parathyroid. Surgery remains the standard of care. In the future, this could be evaluated with more publications and might be a treatment option for patients with parathyroid conditions.
I can envision a possible place for radiofrequency ablation in hyperparathyroidism in patients who are elderly, in patients who refuse to do surgical intervention, in patients who only want to do a medical treatment only, where we try to normalize their calcium level without a cure per se. And if we can imagine that with radiofrequency ablation we can reduce the volume of the parathyroid that is over-secreting, possibly we can achieve a better control of hypercalcemia in those patients who do not want and refuse to do a surgical intervention.
You have to be able to localize the parathyroid in ultrasound. We are very well experienced at finding the parathyroid tumors in the neck, but even our success rate is between 60 and 70%. So there are certain limitations. Also, parathyroid tumors can be in very tricky situations in the neck. For example, the first and the only case that we know of that's been done in the US, we had to use a technique called hydrodissection, where cold water is used to separate the tumor away from vital neck structures so we could safely ablate them, and we were successful in being able to do that, and that was a very important technological hurdle that we overcame.
Kind of evaluate patient for higher risk of bleeding disorder or bleeding complication. Also for female, you want to make sure the patient is not pregnant. For the treatment, you are checking the thyroid function test, evaluating if the patient have autoimmune thyroid disorder. Those patients have a higher tendency to become hypothyroid over time. After treatment, you're monitoring the thyroid function test to evaluate if there's any progression into hypothyroidism or if there's a normalization of thyroid function test after the treatment for hyperthyroid nodules and toxic nodules.
Have guidelines been established in the U.S. regarding who is a candidate for RFA treatment?
Obviously, this procedure is designed to avoid unnecessary thyroid surgery. And when you look at, we're looking at treatment mainly for benign disease as of now. And benign thyroid disease surgeries are in fact quite common. Majority of thyroid surgeries is done for possibly benign disease in the US. The first requirement is to make sure that the lesion that we're treating is benign. Number two, we have to make sure that it's in an area where we can safely ablate it, which is, really not that hard to establish. The total number of patients treated with RFA in America is probably not even close to 100 as of now. We have copied guidelines from other experienced luminaries like Dr. Beck and the other studies published in Korea. We require at least 2 benign biopsies of a non-toxic nodule and 1 benign biopsy for a benign appearing toxic nodule.
Look at the American Thyroid Association guidelines of thyroid nodule biopsy. They recommend a biopsy first being benign. If you are suspecting that the nodule look malignant, they recommend repeating a biopsy in 9 months to a year or in the first year after the initial biopsy. If it's benign again, they recommend stopping monitoring that nodule. There's data indicate if you have 2 benign nodules of one single thyroid nodule, the likelihood of malignancy is less than 1%. And I think that's what is based on most of the guidelines we see from Europe, Italian guidelines, and the South Korean guidelines, indicating that if you have 2 biopsy being benign, then chances of cancer in that nodule is significantly low. It's low enough, as I mentioned, in the American Thyroid Association, they recommend stop monitoring that nodule. Toxic nodule, we use a benign biopsy. Some argue that toxic nodule are not different than benign non-toxic nodule and malignancy risk. But there is also published data, old traditional data indicate that toxic nodule have lower likelihood of malignancy. There is really no differentiation between the size of indication for a radiofrequency ablation or not. American Thyroid Association do not differentiate in the size of the nodules.
As far as we are concerned, the requirement basically is that it's a nodule that's benign and you're a good candidate for RFA. And if the nodule is bothering you in terms of symptoms, that is by itself an indication for treatment for us. In fact, our combined experience is close to 30 years treating thyroid patients, and we can tell you that different people are bothered by different sizes and different locations of the nodules. Some nodules can be even about 2 to 3 centimeters in size. As long as they're putting pressure on your trachea or your esophagus, you're going to feel them there. Whereas there are others who are minimally symptomatic even with a 10 centimeter size nodule. So it varies, but as long as you're bothered by these symptoms, that can be compression or cosmetic in terms of the way how it makes your neck look or the way you feel when you swallow, you can be a candidate for evaluation for radiofrequency ablation.
So we like to a complete radiofrequency ablation on one side of the neck, not both sides at the same time, just to reduce risk of complication happen. If hematoma or bleeding or any pressure on the trachea, it will be easier to manage and control if it's one-sided compare both sides. There is no limit on the number of nodules you can perform in one session. You can, if you have 2 nodules or 3 nodules on the same side, treat all those nodules if you confirm they're benign. Fortunately for us, we did not see any nodule up till now that did not respond successfully to medical treatment, which is defined by shrinking by half in the first months to 6 months after treatment. But I would imagine if there's no response or no success in the first months to 6 months, repeating treatment would be something reasonable.
Each doctor has a different setup for this procedure. Do you do your procedures in a hospital or a clinic setting?
We have the ability to perform them both in the office with conscious sedation or under local anesthesia, or perform them in an outpatient surgery center. It all depends on your preference, comfort, and your other disease comorbidities. We obviously want to perform it in the most safe possible setting. And so the answer is yeah, both those options are available.
Do you prefer local or general anesthesia, and why?
We avoid as much as we can a general anesthesia. We want patient to be awake, able to communicate with us so we can monitor a voice during the procedure. We do not think that if the patient is unconscious, we'll be able to monitor the voice as clear as possible. So we generally prefer as much as we can local and a conscious sedation versus a general anesthesia.
Patient comfort is paramount, and whatever we can do to make this procedure comfortable for them, the better it is. And so we don't have any rigid philosophies that we go by. Patient comfort is our number one priority, and so we've used conscious sedation quite a bit with pain control. Most of our patients report minimal to no pain at all during these procedures. To make this available, affordable for whoever needs this procedure, and we work with them as much as we can to make it happen.
I 100% agree with Dr. Ahmad about that. One thing I would say there, it's really it depends on what is required for treatment of that patient. Is this a procedure done in office? Is this procedure done in surgical center? What additional costs will be acquired depend on local anesthesia versus a conscious sedation versus a other type of evaluation or treatment or monitor is needed. So I would say it's variable. I would say I don't think there's a fixed cost that we can estimate. It's really variable, depends on what other issues going to be associated with the procedure itself.
How many patients in all have you treated with RFA?
We first started doing this in 2018, so we've been at it for quite a long time. So we have a pretty high volume. I'd say between 30 and 35 patients treated already, and we're treating between 3 to 4 people every month. So the number keeps rising up, and I wholeheartedly agree with the axiom that there's no substitute for experience. As we have done more, we've gotten better and better at doing this. I feel we can do it more safely with more experience. So yeah, we really appreciate the numbers that we're getting, and we understand that has a positive impact on the outcome of the procedure.
In your opinion, what is the timeline for these procedures to become more mainstream?
I don't have a timeline, but I can say to you, looking online, I see more and more major centers coming up and starting using RFA, from the Mayo Clinic to Stanford to Johns Hopkins. Everyone is really interested in this technology that preserve the thyroid gland for patient and have a better chance to maintain normal function of the thyroid. So when the insurance will cover that, I think maybe in the next year to two, but I do not have solid data to give you an answer.
All we would like to say is that we would like this procedure to become streamlined and mainstream as early as possible, because I think this is a very important option for our patients to have in America.
What are the biggest obstacles to this procedure being accepted and adopted by physicians who are not yet trained?
Obviously, there's been a lot of obstacles. Our biggest obstacles were that none of our professional organizations that we are members of did anything to really support us. In fact, we felt that one or two of our professional organizations were actually hindering the ability for this technology to come quickly here. Why that delay was caused by this organization, we don't know. But that obstacle has now been overcome as more and more people are doing it, and there are no formal organizations which have become gatekeepers, which I think that they were trying to do. Another obstacle is on the technical side. Obviously, a physician needs to be very comfortable around the neck anatomy, being able to do neck procedures. Dr. Aljammal and myself have done over 15,000 neck procedures, give or take, including biopsies, ethanol ablations, localization. So we were very comfortable around the neck, and I'm assuming there's plenty of endocrinologists and radiologists maybe also who are as comfortable with neck imaging and neck procedures as we are, and those physicians would find it much easier. Yet others who don't have that same expertise, who have not done as much work around the neck, would probably find it hard, and I would suggest for them to have more formal training before they start offering this procedure.
What advancements in RFA probe technology are you hoping for to make this procedure even better?
One thing would be the smaller the gauge of the antenna, the least amount of discomfort the patients would have. So right now the thinnest antenna that we have used is around 18 gauge. If it goes down to 20-21 gauge, patient comfort would improve as long as performance of the antenna is not sacrificed. Another important technological investment that we would want is a bipolar electrode to become FDA approved in the US, as then we could use this on people who have any metallic implants. Would be put in harm's way if we used a monopolar electrode, because there would be current flowing through those metallic implants. So that, I think, should be available in the near future, as a bipolar electrode is in existence and is being used in Korea. I think it's just a matter of getting it approved by the FDA here. Another option would be a shielded antenna, which basically would only one side or a crysenteric side of the antenna does the actual ablation, and the back part of the needle is shielded or insulated. That way you can place it closer to a vital structure, and as long as the vital structure is behind the shielded part, it would not get any thermal injury, and you could ablate the stuff anterior to it and superior to it. So that technically would be a good advancement to have also, and I think those antennas are also in existence in Korea. It's just a matter of doing the right safety studies and approval by the FDA, and I think they should be available in the near future.
Can you tell us about the biggest thyroid nodule that you've treated to date?
36 centimeter volume nodule that we ablated, which is down by more than 50% in size already. And the patient's ability to talk and sing and swallow has improved significantly, and we expect it to hopefully get a little more smaller, but yeah, that's probably the largest nodule that we had, around 36 centimeters in volume.
Do you provide physician training at your clinic?
We do not have up till now a training program, but we did have a few physicians who came over to observe RFA procedure done. All the three were endocrinologists who are experienced in doing ultrasound guided final aspiration. We are hopeful in the next few weeks to months to have a training program for training other physicians for performing RFA.
What is your opinion about the various different physician specialties that are all being trained in this procedure to help thyroid patients?
All of us should work as a team. All of us bring different things to the table, and as endocrinologists, we bring our knowledge of thyroid disease on the medical side. Radiologists bring their vital structures, approach, anatomy. The surgeons bring their own expertise to the table. So I think working across all specialties would be very beneficial to this. As far as in the US per se, whose health system I'm very familiar with, I believe that this procedure will likely be done by all three specialties: endocrinologists who are trained in thyroid disease, radiologists, and surgeons.
Now the big question is, let's talk about thyroid RFA for cancer. Do you see this becoming a mainstream treatment, and if so, when?
So the South Korean at this time, they do treatment with radiofrequency ablation for papillary thyroid cancer less than 1 centimeter. Also, I can envision radiofrequency ablation in patients who had multiple surgery on their neck for papillary thyroid cancer, where additional surgical intervention may come with more morbidity, considering radiofrequency ablation and treatment with lymphadenopathy with radiofrequency ablation would be a good choice, which there is published data of South Koreans show superiority even compared to ethanol ablation. And also a possibility of treatment for uncurable malignancy in the neck, where we're trying to debulk disease with a lower complication rate, maybe also a possibility in the future. But again, we don't have long-term studies to confirm safety in those situations, and it may be individualized case by case, but not maybe the mainstream treatment.
Yeah, I agree with what Dr. Aljammal says, that we feel that in the future there are going to be small thyroid cancers that become treatment targets for radiofrequency ablation, but as of now we don't have enough safety and efficacy studies from within the country to support its use. However, in certain situations, like Dr. Aljammal said, somebody with multiple neck surgeries who's not a good surgical candidate anymore, with a recurrence of thyroid cancer in a lymph node in a tricky area near the nerve or some other vital structure, we can buy time for patients by doing radiofrequency ablation or even eliminate the lesion completely. In fact, Dr. Aljammal and I have done a radiofrequency ablation for a similar case of thyroid cancer that was recurrent, and she already had 5 surgeries before, and this was the only option that was deemed safe by our local tumor board, including the surgeons, and we were able to use that hydrodissection technique and remove the tumor metastasis away from vital structures, and we were able to shrink it down to a manageable point until other treatment modalities are available for her. So that again is also probably the first case of radiofrequency ablation done for recurrent thyroid cancer in the US, and we performed that, I believe, about 7 months ago.
If you would like to follow these doctors on social media, you can find them on Facebook under the name Thyroid Ablation.
Thank you very much, Jennifer, and hope to talk to you soon. Bye.
Thank you so much for taking the time to do this interview with me. I am so thankful for all of the work you've done in the research and promoting this procedure to patients who desperately want an alternative to surgery. And I just appreciate your website, because that was my first exposure to RFA in any form whatsoever, and it was just instrumental in helping me to find that this was a treatment that I could have to preserve my thyroid. So from the bottom of my heart, thank you so much for that, and for all of your continuing efforts to help patients with thyroid nodules. Be sure to hit the bell icon, because you won't want to miss my next video, which will be my trip to Virginia to get my second RFA procedure on my thyroid nodule, as well as my kidney cyst being treated with PEI. You don't want to miss that. And how long should you wait between How long should you wait between How long should you wait between